grand rounds for the 2024-2025 Critical Care Institute of Critical Care Medicine grand rounds. It is my pleasure today to introduce Dr. David Reich, who is the president of Mount Sinai Hospital and Mount Sinai Queens. Dr. Reich joined Mount Sinai in 1984. He is the Horace W. Goldsmith Professor of Anesthesiology and was the former chair of the Department of Anesthesiology prior to assuming his current position in 2013. An academic cardiac anesthesiologist, he has published more than 200 articles, editorials, and book chapters. And as a hospital executive, he has enhanced safety and quality by forming an Institute for Critical Care Medicine, rapidly deploying digital innovation tools, including AI-enhanced clinical decision support, and leading in COVID-19 care and diagnostics. He is the executive sponsor of the Mount Sinai Center for Transgender Medicine and Surgery, and a ton of other accomplishments. I'm going to stop talking and allow Dr. Rich to talk to us today about artificial intelligence in hospital medicine. Thank you so much.
Thank you. And I'm going to start by acknowledging that I work very closely with someone who was originally a nurse on the floors of Mount Sinai Beth Israel and recruited him to be a director of clinical decision support at Mount Sinai. And I just wanted to acknowledge Robbie because some of the slides are shamelessly stolen from Robbie. So we'll get started. No disclosures related to this presentation. This is where we're going as an organization. You know, why AI? Well, because everybody says AI these days. You must hear it 12, 15, 20 times a day just listening to the press. And it's become very hyped recently, as we know. But it is really an unprecedented and revolutionary technology. And it's already beginning to change healthcare. But I would note that within healthcare, we have to be more conservative than other industries because so much is at stake with our patients. And also, if you think about it, doctors, nurses, respiratory therapists, dietitians that we'll get to later, everyone's licensed. So you have to be very careful because your license is what you're using to make diagnoses and to prescribe treatments. And same thing for nursing in terms of the professionalism. So it is actually incumbent, I think, more upon us in healthcare than in other industries to exercise a very much a higher level of caution. So improved diagnostics. Well, the idea is that we should be able to analyze data more rapidly. Before when we had paper charts, we used to joke about if it's more than an inch thick, that's a very bad prognostic sign. And we had trouble getting through them and trying to figure out what the true and most important things we needed to internalize to provide a safe, patient care plan. Now we have Epic, and it's a different problem, but it's the same problem. How do you find the important items in massive numbers of notes that appear in some cases just show up randomly? Research acceleration. This is not what we're going to be going in today, but the idea is to accelerate discovery, optimize clinical trial processes, project drug candidates, and maybe even design drugs. Operational efficiency. This is something that you'll see a lot behind the scenes. I don't think it will be very long until we have AI tools that are helping us manage our OR schedule and our blocks for our doctors to see patients in offices, for example. There is already a shadow war going on between health systems and payers in terms of who can get the best payment and who can deny the most payment, because a lot of financial processes lend themselves very much to AI tools. And then finally, patient experience. How can we, as you'll see later in this talk, find people who are destined to need a little extra help along that pathway? All right, moving on. We just want to think of the AI focus areas. We're not going to do research today. We're not going to do so much teaching and learning. We're going to focus a little bit more on clinical operational, just to provide some examples that would fit within a talk of this length, and also give us an opportunity to have some, I think, hopefully some very good back and forth about where we should be going, especially as clinicians using AI. The reason I showed this slide, it's a classic slide from all those talks on population health. Remember population health? We used to say that every other word before we got into AI. And pop health is a really very important concept because we tend to see the people at the top of this pyramid. we who practice cardiac anesthesia, critical care, we're dealing with the sickest of the sick. And there's a tremendous amount of spend that occurs here. So I think we have a responsibility when we think about how we responsibly use healthcare dollars to take into account what we can do, especially in a critical care context, to best manage those people who are at the top of this high-risk pyramid. Some people say in the US we spend 80% of our dollars on 20% of the population and 50% on 5%. You know, it's just, I don't know about the numbers per se, but I think the point is well taken that we are the ones who are seeing the patients who are the highest consumers of healthcare dollars. I'm going to go to something which is not AI for the moment and actually not implemented in the ICUs, but I want to talk about it because AI is, you need something?
I think the screen is not being shared. Thank you.
Is better? Okay,
Yes.
very good. All right, thank you. Something that frankly was a problem. What happens is if you have a Vocera badge, and these are not in the ICUs but on the floors, and your patient is attached to telemetry, if the telemetry system detects an arrhythmia, we have this middleware, and that middleware sends the alert to the Vocera badge of the RN who's monitoring on that floor. In the old days, you used to have people sitting 24/7 in front of screens, and they would get sleepy and they'd miss the arrhythmias. It was actually a pretty good system. And so we already had a mechanism at Mount Sinai, and other hospitals as well, for being able to alert people through a device which is on someone who has 24/7 responsibility for the patient. And what we had seen, just in quality, and something that really annoyed me as a hospital president, is seeing people in a hospital, you know, a top-rated hospital, who were dying of hyperkalemia on our floors. I mean, that was after the potassium came back. It was just not being treated. You know, the joke, which isn't so much a joke, is that when you have a critical laboratory, you probably know the laboratory has to call the nurse on the floor. That's the throw. The nurse has to read it back to the laboratory person. That's the catch. And then the nurse is supposed to pass it along to the provider. However, you know, they might pass it along to an intern that's, you know, at 2 in the morning and they fall back asleep. So that would then be throw, catch, pass, and fumble. And that'll be the last time you'll hear me do a sports metaphor, by the way. But what happened here is when we set up a system, which is still in place today, that annoys the heck out of our nurses because every 30 minutes it goes off until there's either a repeat potassium, orders to treat the hyperkalemia, or I think those are the two main categories. There's probably a third one there. But before the best practice alert, which is what we're calling this because it's rule-based, it was about 190 minutes to get a mean time until the treatment was ordered and taken care of. And we cut 45 minutes off it right away. I'm sure it's gotten better since then. And by the way, I hate to say it, but the only hyperkalemia death I've seen in recent years was in an ICU. Because we figured we didn't need it in the ICU. Everyone's already there. But just to prove that all hypotheses will, you know, if you test them, you'll always find a problem, right? So next, thinking about how we create models. In general, it's about taking your historical data. We'll get into the types of data later, but it's easiest to start with structured data in an electronic health record. It's all there. It's mineable. Very easy to take. A little harder, we'll come back to imaging in the future. Genomics is very much the future, but for now, it's mostly data which is an electronic health record. Then you've got the phase of prototyping, development, and validation. And then when you have a predictive engine, you have to do the hardest part, which is build it into a workflow. And I'll tell you another joke, which is not a joke at the beginning of this, which is in our experience in implementing clinical decision support AI, it's 20% data science and 80% implementation science. If you don't build it into the workflow properly, whether you're a doctor or a nurse, you're just going to cause alarm fatigue. And we all know what alarm fatigue is because we take care of patients in critical care settings and there's a lot of beeping going on. And so how do you make sure that it isn't just another beep which gets ignored because it just happens too frequently? That's where the tuning comes in. So you can't get through a talk like this without this kind of flow diagram. And so I want to take you through it just a little bit. If we look here On the upper left, what you see is an electronic record, sort of, we'll describe it as an Internet of Things, which is things that are not in the electronic record. Let's say that's a wearable, or it might be, you know, alarms being generated by a device. And then that all feeds into a centralized database. We have a data lake. There are all sorts of different tools. You got your MongoDB, you got your this, your that. But the point is the data flows at Mount Sinai almost instantaneously from multiple systems, especially from the electronic health record, into a centralized data lake, we'll call it. And then that information can send a data stream across to a machine learning algorithm. This is the data science environment, and that sort of throws it over the fence towards the, we'll call it an inference engine. And so we might be training it, so it may not throw anything back, but once it's trained, it may very well throw it back across the fence into the AI prediction. The reason we put clinician feedback here too is a very important concept to take into account when you're working with AI is the concept of reinforcement learning. If I tell you, well, I'll use the example we'll come to later about malnutrition. We'll come back to it. If I tell a dietitian, go see this patient, I think they have a very high risk of severe protein calorie malnutrition. The dietitian sees the patient. There are only two possible outcomes. Either my prediction was right or it was wrong. And their documentation provides clinician feedback, which ends up going into the inference engine so that version 1 is okay. We decided it was okay, so we implemented it, but version 2 gets better because of the feedback. So just remember the concept reinforcement learning. That's what we have to build into these tools. And of course, you know, once we have the centralized interface, it can send the prediction. However it gets there, it could these days be, I really should put the platform of the electronic health record, because Epic, you know, I don't really always drink the Epic Kool-Aid, but they serve as a very nice platform for us to communicate. And so some of the AI predictions are seamlessly integrated into the Epic workflows. But we also have the concept of the mobile app and Vocera, but I think you got the idea here. So what's going on at Mount Sinai? I'm going to go over 4 of these, but we have, I actually talk a little bit about falls as well. But the idea is that it's possible to create products. Why do we call them products? Because realistically, it's like a commercial product. You have to build something, you have to integrate it into the workflow, you have to work with the team, and it has to be done in a sort of a constrained domain. If you don't do it in a way which is understandable, something where you can develop, if you just had an AI prediction that did 10 different predictions, then you know how are you ever going to get the feedback about whether the module that you've developed is actually working to be able to do that reinforcement learning. So a lot of things going on, some of them in the background, but let's start with falls. This, on the top here, there is anyone who went to nursing school learned the Morse scale. And the Morse scale is a way of assessing whether a patient is at high risk for a fall. Only problem is, if you look at these receiver operator characteristic curves, you see that it's not so good. All right, let me explain the curve for a minute, since not all of you may be ROC nerd types. So if you had a coin flip, and that was your best predictor of whether someone had a high fall risk or not, and you flipped it, you'd have heads or tails, so you'd have 50% chance of getting it right. So you can never really get worse than a coin flip. So this line of unity right here, this diagonal line, underneath that line is an area of 0.5. A perfect test when we look at sensitivity versus 1 minus specificity as you change the criterion, a perfect test, the line would go up the y-axis and then take a sharp turn to the right and go completely across the upper x-axis there. And so that would be an area under the curve of 1.0. So in general, if it's greater than 0.7, you know, it's okay. It has some value to you. If it's greater than 0.8, that's considered pretty good. If it's greater than 0.9, you have to be a little careful. You might have overdone it. You might have overfit the model. So you have to be a little cautious in terms of whether it really plays out well in real life. So just sort of remember that this area under the receiver operator characteristic curve, most people call the C statistic. And so you'll see a lot of C's here. And so what we did with good old-fashioned multivariate logistic regression, which some people actually consider machine learning. I used to just do it to get papers published in anesthesiology and in other critical care medicine and other journals, because that was just how we did our multivariate risk adjustment. Turns out that's a very good tool. And so this is a very simple and elegant way. I think it's elegant, whatever. It's a simple, which I think is elegant, way of doing falls prediction. And what you see here is that it takes into account the actual Moore scale, which has to be done, and other things that were in the medical record, like restlessness, inadequate nutrition, friction shear potential problem, and looks at different drugs that the patients were on, and looks at laboratory abnormalities. And what it does is just create a risk score. And what happened here is that in the past, if you look at Morse high, the green, there were a lot of Morse highs in patients that turned out to be mid to low risk patients. And what did that really mean? If you went to it's still to this day, I see it a bit. If you go to a patient floor at Mount Sinai, what's the color you're supposed to wear when you're a falls risk? Anyone?
Yellow.
Yellow. And you're supposed to wear yellow socks. And what happened is yellow socks became a fashion statement for patients rather than anything which was truly predictive of anything. So we're doing better now. And the reason we're doing better is that these greens here are now gone, because when we look at the low and mid risk by what we're calling this enhanced Morse, you are seeing much better prediction. So the point is, you have limited resources. How many beds do you have near the nursing station? How many PCAs can you assign to do a one-to-one? There are just not that many. How many people can you put and would qualify for the remote patient monitoring, that video thing where you got the person in the command center says, "Oh, Mrs. Schwartz, don't get out of bed. We're going to send someone. Don't, stay in bed, stay in bed." So, those are resources, and those resources are all expensive. So if you can take resources and bring them to the right patient at the right time, we do better. That's a theme. Bringing the right team to the right patient at the right time. We're going to come back to that over and over in this. This one is clinical deterioration, and you should be very proud of this, because this was done here at Mount Sinai. We see Dr. Coley Seth here as one of our authors, and we see Robbie Freeman, who did his work. I annoyed them. By the way, I want to point out that I was right and they were wrong in the study design. I'm going to get to that in a minute, because I like doing a little "I told you so" along the way. But this was published this year in Critical Care Medicine in July, and it was published with a very nice editorial. And we'll come back to just why that happened. We spend a little bit of time on the study, because it was done here at Mount Sinai, and it was done with the help of the rapid response team. And just to summarize it, 4 medical surgical units, not ICU, just 4 medical surgical units, 2 of them primarily medical, 2 of them primarily surgical. And what happened was the alerts were sent to either the RRT team if it was a high-level alert. We thought there was a very high risk of clinical deterioration. And if it was sort of a medium-low alert, we alerted the nurses on the floor, and they monitored vital signs more frequently. I think like once an hour for 4 hours. They just did a little intervention. And then between July of 19 and March of 2020, obviously we had to stop at the beginning of COVID. Everyone noticed this place got a little crazy then. We studied 2,780 patients. The issue, and why we had trouble getting it published, until 4 years after the data collection ended, was it was underpowered. We were anticipating studying 6,000 patients, and it's hard, when the statistical thought police are watching you, and that's going to happen anytime you try to get a paper published and it's underpowered. That's a challenge. So, but we studied 2,780 patients. The primary, and this is where I'm going to have my "I told you so" moment. And as everybody said, we're going to design this, and the primary outcome will be low. We're going to hypothesize that we're going to lower the incidence of escalation to the ICU. And I said, how do you know that? If you see people who are deteriorating, how do you know you're not going to scoop them up and bring them to the ICU? And so I told you so. I was right. Well, you'll see the results. But the important one actually is the secondary outcomes. The secondary outcomes here, we're looking at orders placed for cardiovascular support. So clearly you came in, you saw someone was not doing well clinically. And, you may have given fluid, started, whatever, epinephrine, whatever those orders were. And then, of course, combined in-hospital plus 30-day mortality, and ad hoc looked at time to ICU escalation and time to hospital discharge. And although it's this with this little plot here, it's a little harder to see these things sometimes when you're sitting far back. The key thing was that the escalation worked in a way that you weren't really expecting. According to the primary hypothesis, we found the opposite result, that approximately 43% more likely to escalate to an ICU from the floors where this alert system was implemented versus control units where the alerts were generated, but they weren't sent to anyone. They were just suppressed. And so the secondary outcome of received cardiovascular support orders, wow, 74% on average of patients who were in this cohort had some sort of cardiovascular support order put into the chart, usually obviously treatment of hypotension or of, borderline hypotension. And then section B, which is probably the most important one, is in-hospital 30-day mortality was 24% lower in the point estimate, and it just barely made statistical significance, but remember, it was an underpowered study, so it was actually kind of surprising that we saw a mortality signal there. And then the ad hoc outcomes, we did see that people were almost, in the final version of the statistics, it didn't quite make significance, but people were moving towards faster hospital discharge, but there was a clear signal towards ICU escalation within either 12 hours or 24 hours that was strong. Now, another important thing to remember, if you look at the fine print in the study, is we actually sent an alert either to the primary team or to the RRT in patients with an average length of stay of about 5 days. You only send one alert per patient, but 92% of the patients in those units where they were being monitored had some kind of alert. Now, probably about a quarter of those, based upon what I saw when I looked at the analysis, were sent to the RRT. But you have to worry about RRT fatigue. Also, how many people can you go out and see a day? Now, I'm going to stop there for a second and say, when we got the paper finally ready for publication, the person who was going to write the editorial wrote to us and said, so you did a study. Big deal. Fist pump, you got a paper published, you're going to have an editorial, but what did you do with it? And as you may know, today, somebody left the intensive care unit with a list of 15 patients in our step-down units, and they're seeing those patients and they're evaluating them. And in my sort of initial summation, Dr. Sept may, correct me on this one, I would oversimplify it to say about 25% of the time you do something. You see something, it's not good, you wear the fluid, you change meds, maybe you scoop the patient up, bring them to the ICU. 25% of the time, you make recommendations, but you don't really do all that much. 25% of the time, you do nothing. But, and this is the core part, 25% of the time, you have the first serious illness conversation with the patient. Moving palliative care upstream, which is an incredibly important thing for us to do. I don't know, since most of you are pretty young, I don't know if you realize the fights we had about embedding palliative care into critical care. We had intensivists and surgeons that were frankly unprofessional, nasty, dismissive, not quite physically abusive, but it came close to it, to the palliative care team when we first started bringing them around. Now it's part of normal routine. If any of you have bad feelings about palliative care, too bad, suppress them. But by and large, this is something that's happened, and palliative care and critical care are inextricably linked. And so I'm actually delighted because this study, which is very much your study as the Institute for Critical Care Medicine, has resulted in a real change in care at Mount Sinai. And in my opinion, we're doing a much better job for our patients than we did before, because we have such a huge number of patients in step-down care, which is, as it's sort of like, many other places that would be in a critical care unit. But this is Mount Sinai. We only have, 104 critical care beds, and we probably have 200 people that need them. So we have a huge number of people that are in intermediate care. Okay, let's talk malnutrition for a minute. The reason I'm showing you this slide is because when we do some of these predictions, it's possible, you may have heard originally we just talked about neural nets. Now we talk about machine learning, and there are convolutional models, and there are many different ways that people describe machine learning. But in many implementations, the machine learning it provides a prediction, but it doesn't tell you why. You can sort of reverse engineer it perhaps, but when you use certain techniques that do machine learning, such as random forest, the nice part is it can tell you why it made that prediction. And especially in the early days or early years, perhaps, of implementing AI into clinical workflows, it's helpful to tell the clinician why the heck you're sending them to see this patient. So here we started years ago, we started in 2016, 17, sending dietitians to patients that we predicted had severe protein calorie malnutrition. Why, you ask? Well, turns out, of course, we underdiagnose it tremendously. I don't think I need to tell you what the downstream negative effects are in poor wound healing, almost certainly higher mortality, decreased resistance to infection. We could probably go on. I'm not an expert in this area, but we all know that severe protein calorie malnutrition needs to be addressed and treated if we're going to treat people well. And also, this is in the ACGME, they would call it system-based practice. You actually rate a patient as a higher risk by coding a major comorbid condition when you diagnose severe protein calorie malnutrition. And that has two benefits. The hospital is paid more for that admission because it's a higher risk patient, and external agencies that rate us see this as a higher risk procedure. So our observed to expected outcomes, whether that's mortality or length of stay, et cetera, will be adjusted accordingly. We have much more in this hospital to do in the way of coding in that respect. The reason NYU is always number one is not because, in my opinion, not because they deserve it. I really, NYU and I are beyond oil and vinegar, but they're geniuses at coding. They have really, really good people who have reversed engineered a lot of this process. And honestly, if you can't beat them, join them. I think we should be replicating a lot of what they've done related to coding, because they figured it out. So anyway, that's why, I sort of got the team working on this as one of our earliest implementations, but the team had to know why they were being sent. So here in the lower left, you see an albumin of 1.8. You see a length of stay of 9.01 days. You see a low hemoglobin. You see a potassium in sort of a low normal range. And, but I want you to notice the BMI is normal. So BMI is a terrible predictor. You can have people who are morbidly obese that have severe protein calorie malnutrition. You should know, you put them in the SICU and you don't feed them for 12 days, this is what happens. That's why the surgical nutrition service dates back decades here, because we recognized this many years ago. And then on the right, the important thing to know is the EMR goes back to the data science pipeline, because, again, back to the reinforcement learning, the dietitian's documentation feeds the future algorithms, because we know whether we were right or whether we were wrong. So we get better over time. Ta-da! So anyway, we got pretty good. And the other thing you have to worry about is what I would call the Epic snafu. Epic went out there and said, okay, we've figured out AI. I don't know why I'm doing that accent. I just made it up. And we can figure out who's going to have severe sepsis. And we ran it in the background here, and it was actually worse than our good old-fashioned respiratory rate, temperature, hypertension thing that we have going here, the rules-based thing. And since it's a very highly regulated area, and we have to submit reports on it, and I think definitely it's New York State. It might also be CMS, I'm not sure. But the point is, you have to have a sepsis treatment algorithm. And you can't get that wrong. And Epic got it very wrong. It wasn't any better than a rules-based algorithm, which we know is, it's fairly sensitive, but it's also non-specific. A lot of false positives. How many times have you run out on a sepsis alert and you've actually found sepsis? Plenty of times, and you've saved plenty of lives, but you also waste a lot of time seeing people who don't have sepsis. So the problem was, and I joked when I ran into him, who's the head of AI at Epic, I said, well, if you develop an algorithm on corn farmers in Nebraska, it's not going to work so well in East Harlem. And he said, how did you know I used a Midwestern data set? And the answer was, of course, I didn't, but they made a cardinal mistake. You've heard that expression, all politics is local? I'm going to argue all AI is local. You have to run the algorithms on your population. Are we here at Mount Sinai the same as what you have? Epic is very close to University of Madison in Wisconsin. Of course not. Look at our diversity. Look at the proportion of people with lower socioeconomic status. Look at the prevalence of the social determinants of health. I could go on and on. But the nice part was the algorithm we developed at MSH, it worked almost as well everywhere within the health system because there was enough similarity in our New York-based health system that this algorithm worked pretty well. And so that's the lesson, is look at your local data. And that's why every large organization is going to have to become competent at developing AI models, because the models have to be based on local data. And if you look at us starting in 2016 through 23, we basically more than tripled the diagnosis of severe malnutrition. And we didn't make it up. The dietitian had to see the patient and actually make the diagnosis, but we were sending the right team to the right patient at the right time. And then I would add the fourth, and then they can provide the right treatment. So that's a key principle. And I want to note that this algorithm just in June, we won the 2024 Hearst Health Prize. And that's a good one. So fist pump, all of you. Mount Sinai got $100,000, which, as you know, completely cured our financial problems. All right. Next, delirium. I'm trying to get you to laugh while I'm crying. All right, delirium risk prediction with NLP. All right, delirium. How many patients in the ICU today have delirium? You probably lost count, right? It's a huge problem in healthcare. Much, obviously ICU delirium has been known, and between CAM ICU and other scores, we've known about it for decades. It's not a new thing. When I was a resident, we called it sundowning because it would happen more often at night, and maybe people still call it that. But the point was, when we tried to do our first delirium model, we didn't do so well. And you're going to see just how that looked initially and how we improved it. This thing is, the structured data worked really well for malnutrition because there are a lot of labs in there, a lot of medication use, a lot of structured items in a record, length of stay, etc. Delirium, other than age, it's kind of hard to figure this one out. I mean, of course, there are people who are more prone to it and various deliriogenic medications that we should be stopping, but we weren't doing so well. So we decided early on we had to think differently. And so we started using what people call natural language processing. So what does that mean? Is you take the written notes, and those notes are everyone: social worker, the physical therapist, the nurse, the physician, the APP. Everyone's notes are being parsed and analyzed. And it's called an NLP classifier, and it creates a feature vector. And then if we put it again through random forest, because we like to tell people why we make predictions, even though there are many ways of doing AI predictive analytics. And then we ended up with a final probability. And you can see keywords from clinical notes that were very much associated, or snippets of words like, confuzz, alter mental, follow command, metabol, dementia, infect, impair. So these snippets, these fragments of words, were reasons why we were seeing signs of delirium, but we weren't connecting all the dots and just realizing it and, frankly, getting together a team to come treat it. So here's where we started on the right. If you look at version 1.0, area under the curve 0.72, still respectable, but not really something you want to write home about. And then version 1.1, still with just the structured data from the record, 0.73. It's like a presidential poll within the range of error, right? So we weren't really any different. And then we added the natural language processing, and it came up to 0.94, which is kind of scary accurate. And why is it scary accurate? Because our teams were noticing it. They were seeing signs of delirium, even if they didn't call it that. They were noting the patient was somewhat confused and that they had to reorient them, but they weren't necessarily experts that understood how to diagnose delirium. And so this is something where is a theory. The point is you have to keep adding new tools. And so natural language processing is a very important tool. I'm not going to spend a lot of time on this one. This is predicting the in-hospital patient experience. And what you see here is that we rolled it out across multiple areas. I'll just point out that we are rated based upon HCAHPS, the hospital, it's a hospital patient satisfaction survey. We have to send it through a company called Press Ganey to 100% of our patients. And the interesting problem is there are low response rates, and New York has very low ratings for patient experience in general. And I'm delighted to report that in Florida during the winter months, the patient experience scores go down. Okay, maybe it's a tough clientele. But the joking aside, this is real. Experience is experience, and so being able to, if you look at our case control group, what we were really trying to do is to just figure out exactly how we could improve things. And with the cases, what we were trying to do is to do an outreach to patients proactively with our patient service center team. And what you can see, because we were getting a signal, strong signal, that, or we were concerned anyway, that there was a race and ethnicity component to this, because you often see that, that there's a lot of structural racism. We know that it's embedded throughout healthcare and all throughout society. We were actually not surprised to see that there were some differences, but the fascinating that Black, Hispanic, and Asian in general had lower rates of dissatisfaction than the white patients. And I'm not trying to make any conclusions about this, but the point was that was an initial signal in what we were seeing with patient experience. So we looked at it with this intervention, and it seemed to work. So let's start to wrap up. What are the AI lessons learned for this group, for the ICCM? Bring the right team to the right patient at the right time. Don't make the diagnosis with AI, but identify the people who are most likely to have the diagnosis and get the experts to the bedside. You have the license. You have that diagnostic ability. Yes, 5, 10, 15 years from now, AI may be better than us in certain respects. But once again, unless it's sort of approved by the FDA, you have to really worry about what the future is in medicine. So I would argue it isn't AI is better than people or people are better than AI. It's about augmented intelligence, that you help our staff achieve higher patient safety, quality, experience, and frankly, better healthcare economics because we use our resources more effectively. And so the thing about the electronic health record, I don't really expect Epic to do a tremendous, I don't think it's going to do a tremendous amount of, how should I describe it? I don't think AI is going to basically Epic won't do the work for us. They're not going to have a great way of doing the local analyses. They're not going to have a great way of building the teams and developing workflows. You have to do that locally. But the electronic health record is a great platform for communication. So whether it's an Epic secure chat message or whether it's a flag, because what I showed you before for malnutrition, that's actually screens in Epic that our dietitians see. And I'm not sure quite how it works in terms of ICCM and sending the person out every day with a list of 15, but whether that's on Epic or whether that's a scrap of paper, the point is you have to have a communication platform. And finally, I'm just going to give a snippet that conversational AI is going to be very important, not so much for critical care, but for communicating with patients. So helping people get an appointment, helping people get their results. We do it even with my Mount Sinai, the Epic My Chart that we rebrand. we're not so good at communication. We're not so good at access. And so many other things about what we do in healthcare will be improved because, frankly, and I can train an AI avatar to be nicer than someone who picks up a phone pretty quickly and help them solve various problems. And it's also less expensive. So what we're moving towards is this concept of an omni-channel experience, that you're connected through your mobile app, you'll be connected, to the physicians, and looking at it that way. And I'm going to just jump to the last slide here. Think about multimodality. I talked about electronic health records. I talked about clinical notes. I didn't yet talk about waveforms, the vast imaging data that we have. This is just radiology. It's also pathology. The multi-omics, not just the genomic analysis, but remember, we have 1 million people being sequenced now with that Regeneron project. So we're going to have genetic information on a vast number of people. And by the time that project is done, with the gradual decrease in the cost of genomic analysis, we're going to have tremendous database of genomics. So that's where in the middle, you've got to bring it together. You harmonize the data and develop predictive algorithms that get progressively better and better. Because as you saw, when we added natural language processing, things got better. So you have to keep adding additional tools. And the idea is that you validate, you calibrate, you implement into the workflow. 80% of the work is the workflow. And then finally, clinical deployment. So I'm going to stop there so we can have some Q&A. And thank you for inviting me to speak to you today. Thanks.
Thank you for an energetic talk. I enjoyed it, and I find AI to be a useful tool. Problems occur when I remember when we had a complete burnout, the whole system fell, and people didn't have paper. We had to record our clinic visits on paper, and then it was a chaos because nobody remembered how to do it, especially the new house staff. The old people like we used to use paper did know what to do. But then the problem is getting all those records back into the electronic record sometime after, when we see hundreds of patients in one day. That's a job in itself. So that's one problem. Is there a way to circumvent that in any way? I mean, generators take care of electric power, but not when there's a systems breakdown. The other thing is surveys. I've dealt with that for many, many years, and I think the surveys are lousy.
We can't hear you, Dr. Brown.
The surveys, there's such a delay between the patient leaving the hospital, if they go home, to when they get the survey. And most people, the language is not a comfortable for most patients, I've discovered. And so they just throw it in the trash because they say it doesn't make any difference. So there isn't any way, a good way to educate, because you can't tell the patients when they're leaving the hospital to give you a good evaluation. But I do think giving the patients the survey forms when they leave the hospital will connect their visit to the survey to that particular visit. So that patients are in and out in 2 different locations within the system, may have several visits, but wind up getting 2 surveys down the track. They don't know which survey pertains to which hospital visit. So that is another reason why they throw them out. So I wondered if we depend so much on the HCAP's responses, I just don't trust them whatsoever. So what are your comments?
Well, thank you for your comments. Unfortunately, we don't really have a choice with HCAPS. It's dictated by regulation, and it has to be done in a very specific way through a series of vendors. So I understand your concerns, but there's actually nothing Mount Sinai can do about it. And I fully agree with you, when our computer systems crash, it's a bad thing.
Anyone in the, Dr. Colson?
Yeah.
Thank you for doing this talk. I have a general comment and questions. We have various AI platforms, and ICCM collaborates with quite a few. For example, recently we got involved with Palantir.
Mm-hmm.
We are involved with clinical data science group with Matt and Robbie and yours. And now we have our own AI director. I don't know if Ankit is on, and we are trying to develop different algorithms. Does Mount Sinai have a plan to integrate all these platforms to come up with, robust or integrated way of doing things, or?
Well, I think you've hit a very sore nail on the head, Doctor.
Sorry.
Yeah. No, the challenge is that when you have a technology which is becoming ubiquitous, you can have chaos.
Yep.
And so the organization has developed an AI governance structure. Dr. Darrow, our Chief Medical Information Officer and interim Chief Data or Chief Information Officer, put together a very nice structure. In fact, I was on the executive committee just today. There's a clinical group, there's a sort of financial operations group, and there is I guess that you call it a finance group. And so when you look at the process, what you really need to do is have a good way of screening. And by the way, some of the way we're going to have to screen is when people present contracts for us to sign.
Yeah.
Because, at that point, especially if it's an external vendor like Palantir, let's say, and even just going back a few months, it was very easy for a group to just put through a contract with no oversight and no central discussion about that. So you're 100% right. You can come up with a lot of different examples, and every department, every division, every resident, every high school student in their bedroom can use AI tools at this point. And so governance is the key, and we have to be a good steward of the dollars of the organization and make sure we don't have 5 people trying to do the same thing. But on the other hand, we don't want to stifle innovation. So that's where the governance has to be flexible, and we want tools to be available. Actually, one of the key discussion points today was that we felt one of our jobs is to do communications about the dangers. Because right now, you can pull up an app on your phone, talk about the patient you just saw, and ask for a differential diagnosis. And guess what? It might actually be helpful. It might come up with something you hadn't thought of, but it might also be absolutely completely wrong and lead you to make a misdiagnosis. Or I'll also give you an example. I should put it in this talk. I keep thinking and I keep forgetting. There was a study published of radiologists that were experienced and inexperienced, and they were asked to say, does this mammogram have a lesion which is high risk for cancer? And then what they did was they had an AI algorithm that was shown to the radiologist trainee or experienced person before they made the diagnosis. And they intentionally implanted errors and gave incorrect AI, diagnoses that they knew were wrong, and they put them in there. And the inexperienced people made a lot more mistakes than the experienced people who said, nah, the AI is wrong, but the AI was able to influence less experienced people more effectively. And I think that's a very important lesson for all of us, that when you implement a new tool, that it has dangers as well.
No, 100%. I'll give one quick example. I was doing some board review questions and things we already know, bread and butter.
Yeah.
Which axis on ultrasound do you use to do a central line?
Yeah.
Everybody knows the answer, right? It's short axis. That's what we use. So I looked at this. I said, has to be a trick question. I asked Siri, which axis do we use? Siri says oblique. I'm like, really? 90% of the physicians use oblique axis for doing a central line. I said, no way, I'm still putting in short axis because that's what we do. So there you go. So absolutely.
Right.
So
very good. There's a question.
Yeah.
Yes.
I mean, it's a good segue into the question I have is, like as a human brain, we fill in the gaps in our memory, we imagine things, right?
Mhm.
And we also tend to, like human brains can lie and rationalize it. As AI gets smart and starts filling in gaps in what it's trying to sieve through to generate a response, right? That would be a concern. So when we are generating these things, how can we keep a check on that? Because like you said, if it gets too good, it starts influencing our decision, even though it's augmenting what we are doing. But if it's coming to that decision based on confabulating something because it's not able to fill up that gap, then it can lead us to the wrong pathway also, right? So like when we are making these solutions, how do we try and keep a check on that? Or like, what are the efforts for that?
Well, you have to remember the term people like to use is hallucination.
Yeah.
But a large language model, like a chat GPT,
Yeah.
it's not hallucinating, it's just a statistical model.
Right.
It has access to massive amounts of data, and then based upon the input, it takes the, based upon the data that are available, it creates the best possible solution using statistical methods, essentially. So it's just a model. And models will be wrong a lot of the time. I mean, how many times, have you had a laboratory result that was an error? Plenty of times. And how did you decide it was an error? You couldn't tell by looking at the piece of paper or the computer screen. You had to use your judgment. So I think we're in a dangerous era, I think exactly as you're implying now, where more information is coming in, and very much relevant to the study I quoted from radiology, it's able to influence people to make mistakes, as well as able to influence people to make better decisions. And so it's a double-edged sword. So as physicians, nurses, other practitioners, it is very much incumbent upon us to do the right thing for our patients. And we're in an early and dangerous era, but also a very exciting era, because we can do things that we never did before. Those 15 patients we see a day, you help a lot of those patients, and that's a very good thing. So don't necessarily disparage the whole concept, but be very cautious about where it works and where it doesn't.
Right. I have one quick question. I think some of the exciting things are using AI to help assist us with some of our more mundane tasks. So like documentation and type of notes with the AI scribes listening and doing some of the documentation to cut down on some of our documentation time and some of the time that we spend that aren't necessarily treating patients. Is there any efforts within the hospital to try to use some of that technology?
Yeah, frankly, that's where we're going to depend on Epic. And Nuance also, which is an add-on to Epic. The ambient listening and the writing of notes, the eventual generation of differential diagnoses, suggesting tests to order, it's happening. But sometimes you want to be the first to adopt a new technology, and sometimes you want to be sort of in the middle of the pack. And so what I'd say is that let's give Epic a chance to do this. This is something I'm convinced they'll do well, because they're used to writing notes. That's their thing. But mostly we wrote the notes, and they were just a passive recipient. So it will help. It was interesting. There was a Newsweek, will AI fix physician burnout? It was 2 days ago. I went to, it was a terrible panel. But Newsweek rates us so highly on everything that if Newsweek says come, I say, okay, what tie do you want me to wear? How high should I jump? But I think the point, it wasn't a really effective thing, but we're all hoping that the documentation burden will be reduced by ambient listening and other ways of sort of observing what we're doing. So it's coming, and I didn't talk about it today, obviously, because there's only so much you can fit into a talk, but it's hopefully will make our lives better.
Thank you.
Question.
Yes, the last question. Thank you.
So with this new industry blowing up, how do we, I understand these systems will likely use a lot of patient data and information. It's a new frontier. How do we ensure that patient safety and patient data is safe, and just in general as an industry?
Well,
Yeah,
cybersecurity is extremely important. Obviously, you have to guard the data, make sure people aren't taking massive amounts of data home on a flash drive to run an AI, tool in their living room on a laptop. But I think the bigger concern I have is not that the data aren't secure. We work hard. I'm sure there are going to be breaches here and there, but not specifically related to AI. The bigger problem is that when you train models with AI, you train them on data that are inherently biased. Who gets better access to healthcare, rich people or poor people? We know the answer. Who gets, to come to a Mount Sinai versus who gets to go to elsewhere general in suburban New Jersey or rural New York? So when you look at data sets, they reflect what happened to people in a very imperfect health system. So I argue it's not the security, it's the actual integrity of the data because if you are training, for example, a data set, and we know that within New York City, we're much less likely to identify people, for example, who are going to have OB complications, who are Black and Latino, because they're living in neighborhoods with less access to care and poor access to care. And that's just one example. There are many examples. So I would say of making sure you have good governance so that we use things safely, but also ethically is a key point. So I'm very grateful that you asked that question because it jogged my memory to talk about the ethics of AI. Thank you.
Thank you so much.
Yeah.